Good morning, all. Thank you, Dr. Harish and the team, for making this morning wonderful. uh, Respected EC members of ISCP and senior and dear friends. Colonoscopy is a topic very close to my heart, but every time ISCP is giving me, and by this I am assuring that unless and until this topic will be dear and near to your heart, you cannot advance as a coloproctologist, that is for sure. Endoscopy, colonoscopy or sigmoidoscopy. Regarding sigmoidoscopy, you can have two options. One is rigid sigmoidoscopy and one is the flexible, which we are doing as a colonoscopy. Now, rigid sigmoidoscopy is a type of procedure. Those who are not entered into the flexible colonoscopy into the practice, but starting with a rigid colonoscope with a small setup, recently passed surgeon recently starts practicing, that is one of the tool. But rigid sigmoidoscope has a special training period and it has a quite deadly complications if you have not done it in a proper manner. So this talk is focused on the flexible colonoscopy. If you want to have learn about the rigid sigmoidoscope, then that will be a separate session, or if the time allows over the period we can go ahead with it. So focusing on flexible colonoscopy. Now any colonoscopy or a complete colonoscopy, to reach to a complete diagnosis, is starts with the bowel preparation. What is the bowel preparation I use in my setup? That is Exilite P. Nothing related with any disclosure or something like that. This preparation I am using since last 10 years and it works wonderfully. Most of the gastroenterologists, they either recommend a PEGLEC like solution, but the only problem with the PEGLEC is the volume is quite high volume, which patient is not tolerating. They give a powder sachet, ask them to make the solution with a 2 or 3 liter water and ask them to drink. But this is a Exilite P is a osmotic laxative. Basically it is containing 45 ml 2 bottles, and this 45 ml solution, suppose we are planning a colonoscopy on Monday. Now on one day prior, that is on Sunday, at 10 morning, I am giving one tablet of Gerbisa or tablet Dulcolax along with the first preparation of the Exilite 45 ml bottle in a cup of water. Okay. Then patient on that day is asked to take the semi-solid food like upma, khichdi and pongal and etc. Then at 12 or 12 to 2, the next Exilite P bottle I will ask the patient to take. The next Gerbisa tablet I will ask the patient to take on the Sunday night. And over this, on the Sunday day, he will be taking around 5 to 6 liter plain water as and when required. That should be the target. So on an average, you can read out what is the bowel preparation patient is achieving by means of how many motions he has passed, what was the consistency of the motion, is it totally watery or semi-solid, and what was the frequency of the motion. By this, on telephonic talk also you can assess if patient has not passed more than suppose average 7 motions in that day, it is not a good bowel preparation. Depending upon the level of constipation of the patient, you can assess it and you can change the dose accordingly. Now, rating the bowel preparation, there is one of the scale, it is given in the literature. Even in the most of the endoscopic books recently, which was the previous talk given by a renowned gastroenterologist, he will also agree with me that every time, even though this is a standard scale, depending upon what is the material loaded in the colonic lumen while you are performing the colonoscopy, whether it is a semi-solid, whether it is a totally solid, whether you can completely see the mucosa, whether it is a turbid liquid or whether it is a clear transparent colon. Depending on that, on an average, suppose in a month you are doing 60 to 70 colonoscopies every day, you can make your own scale of improvement by which you will analyze what type of improvement we will require in daily practice so as to improve a good colonoscopic preparation. The pre-colonoscopic rituals at our center is 95% cases diagnostic colonoscopy are done without any help of midazolam or propofol or fortwin like that. Even though my husband is anesthetist, he will be always a standby. But if you have gradually advancing in a gentle manner, no need to give any type of sedation or anything like that. Second thing is the proper lubrication of the tip of the colonoscope and the rectal lumen inside with a xylocaine jelly is very, very important. Assure the patient that he has to make the sphincter relax. He should not be holding it tight. By making the sphincter tight, he will also be tightening the anterior abdominal wall tightening effect, which is acting as a de-advancement of the colonoscope. Then per rectal examination before putting the tip inside is must. Apply the sufficient jelly. Take out that double glow, wear double glow. Take out the xylocaine jelly glowed finger. Wear a new glow, or you can wear one above the other. Then hold the colonoscope in a proper way. Then hand press by the patient himself. Here, as you are advancing, for example, you have reached to the sigmoid colon. Sigmoid colon is redundant and very much dilated, something like that. In such situation, by pressing the palm of the patient on the infraumbilical area in the midline like suprapubic area, you are going to achieve the decompression of the sigmoid colon by taking patient into confidence, or assisting at respective area. The patient can help you in such situation. Now, safe endoscopy checklist, it is always necessary. Before you put the colonoscope or tip of the colonoscope inside, make assure that all your system is working properly, like suction, light source, the cable are attached. If you need a biopsy, what is the bulb you are taking, all this has to be very properly arranged. And so always, as Dr. Praveen Bhatia mentions in his multiple talks, that recheck, check, recheck, check. So such pilot attitude has to be there before you insert this type of colonoscopic instrument inside the rectum. Now, ambidextrosity. Here at a time we are handling multiple channels. At a time our right hand is engaged into the advancing of the colonoscope, and our left hand is altering or is controlling the smaller wheel and larger wheel. Unless and until you have the practice of with a close eye, where is your small wheel, with right turn of the small wheel, where what your tip is doing, with the opposite action, where is your tip, unless and until in your back of mind you have the idea of how to do and by this action where is your tip, then only you can advance it in a more proper way. So holding of the colonoscope is also important. Initially you can take the help of assistant, but unless until you use both the hands in a proper way, you cannot coordinate with each other. Now, once you have advancing the colonoscope, once you have entered into the sigmoid colon, your every body movement, like right shoulder ahead and back shoulder ahead. So this rotation of your body axis is also altering your colonic tip movement. That has to be understood. Not only pushing is going to act, but whole of the body and mindset should move in coordination with each other is very important. So critical component is the safe and effective endoscopy practice. It is not achieved by blindly, but unless and until you see the lumen inside, then only you have to advance. So core out, the 4 actions are very important to complete the colonoscopy procedure. Scope in and out action, that is very important. If you are not able to progress, 2 step back is the standard dictum. Up and down movement of the wheel, how it is coordinating with your tip of colonoscope, left and right movement, torque, supination and pronation at the wrist joint. These are again 2 important movements. Now here in this video, if you could see, The colonoscope tip is very much important. Initial 5 to 10 centimeter is the most flexible part. Now with the rotation of the small and bigger wheel, try to imagine that how you are progressing. Once you are into the lumen of the colon, suppose in this figure you have the dilated sigmoid colon up to epigastrium. Now once the inflation has stopped, deflation has done, and now you can realize that it is going inside. But unless and until if you do not going ahead, and if there is an obstruction, do not try to push. By this action you are going to give a damage to the one point of the colon, and by which the complications are going to rise, and you can have, suppose in the ulcerative colitis you are doing this colonoscopy, high chances of perforation. Now these are some of the tubes which we get with any type of electric advancement, like dryer of the washing machine or dryer. These have a larger pipes. For the initial advancement and initial finer tunes of the colonoscopy to complete, you can use such type of wires. They are readily available in any electric shop. You can give them various curvatures and fix them, and you will advance into the procedure, how the procedure has to be done. Now this is one more video in which patient has been given a left lateral position. Try to understand that once your left lateral position you are unable to advance and patient is conscious, try to alter the position either by supine. Whatever this surgeon is doing, that is a supination and pronation action, and the torque movement is very, very important. So my whatever take is that not only a single movement is important, but multiple sequential movements are very, very important. Whenever you are achieving taking biopsy, try to imagine that whether your biopsy is at 6 o'clock or 12 o'clock, because unless until you are in the midline of the picture, you are not going to have a complete biopsy, or endoscope cannot give a proper image to have a satisfactory biopsy. Now the next is rotation, supination, pronation, and the advancement. These are again three important movements. So 5 basic rules of the colonoscopy: do not advance without a clear view, do not advance the endoscope if there is any resistance, when in doubt always pull back, use little air as possible, because we have a complete idea in your mind. Being a surgeon, we want it to do more and more actions than to think, and we inflate the colon indefinitely till it distends, and patient will have, if not given anesthesia, patient will be under lot of pain because of the over distension. So minimal air inflation, gentle movements and gentle propagation is very, very important, and few attention to the patient's pain reaction if you are performing the colonoscopy without any type of sedation is very important. Now if you look at the 3 tummies, there is morbidly obese, mild obese, and a taut person. Now the difficult colonoscopy is having the last one, the one who is a fit person. This colonoscopy is going to be little difficult because his tone is more the tummy is relaxed, more the anterior wall, abdominal wall is morbidly obese. Like in a multiparous female, you have lot of roomy space inside, and even mild distension is going to act in this space. So respect the rectum. Try to define that the 3-dimensional anatomy of the colon is important when you are propagating the colonoscope. Patient is in left lateral. Colon can have different shapes and different zones and different turns. So do not try to imagine that colon is like a straw which you are drinking with a coconut water. It is having its initial propulsive movements, peristaltic movements, and this definite curves you have to understand. And for that, the complete lumen has to be in front of you. Reaching the cecum, again the Mercedes-Benz sign, the Y-shaped mucosal fold, and in some cases like Crohn's disease, you have to advance into the tip of the ileum also, from which you have to take the biopsy. So quality indicators of the colonoscopy, you have to make your own quality indicators by usually doing the colonoscopy in a routine practice. Treat the monitor like a clock. Now there are various standard colonoscopes like Olympus. They have, if you want to go for a biopsy channel will come from a 5 5 o'clock position, but for a Fujinon like it will come through a 7 o'clock. So different standard endoscopy companies will have a different rituals and try to make that where is your colonoscopy biopsy forceps is going to come into picture. Now post colonoscopy documentation is also important to improve yourself, that how much time taken, what was my average bowel preparation, and by without anesthesia or with anesthesia I have done, how much bowel preparation I have done, what was the constipation grade of the patient. So these all things are important. So levels of learning cannot be attained in a one go. Here you have to have a unconscious incompetence. By just putting in the first colonoscopy, you will not have a complete idea that by this action what I am going to achieve, like driving a car in a first sitting. But if you get expertise, even without even without touching the steering handle, your car is moving without any type of accident, and that is called as unconscious incompetence. So these are the important levels, and for this achieving without touching to the steering wheel, your car is moving, you have to have a complete change and a learning experience, and what type of accident can occur at which level is very, very important. With this, thank you so much for the attention. Any questions I would like to answer?
I advise my patients to do this thing, have liquid diet at least a day prior. Not only that, just the preparation, Axelite solution or Paglec, but I advise them to have a liquid diet a day prior to the colonoscopy. Third thing is like that curve you were saying about the conscious incompetence. That is also a very important thing, because as a surgeon, like we are not like gastroenterologists, we just get exposed suddenly to the colonoscopy, and like as I talk about me, I have taken this both scopes, endoscope, the upper GI endoscope and the colonoscopy. So, and upper GI endoscopy is very, very easy to learn, and you get the hang of it like anything. But colonoscopy is altogether a different ball game. So one should go very, very slow. I used to call somebody to do for my initial cases to do that colonoscopy, and then slowly I learned that. And this, the most important point is that we should not hesitate to pull back the colonoscope. That is the most important take-home message should be that. We should not think that when we are doing the colonoscopy, we should go one go. The taking back of the scope has to be very, very important. And another thing is, like, we have to know when it is looping, so that we can correct the loop.
So rightly mentioned. To answer your few of the questions, one is leafy vegetables on 1 day prior and semi-solid diet. So that is what I have advocated, that with Exilite P, patient is asked to take a semi-solid type of diet and lot of water. That is the first dictum. Secondly, even though you say without preparation you are advocating, I mean to say, yeah. So carbon dioxide insufflation over the period, yes, it can be done, but in my setup, whatever the Olympus processor I am having, that has a air insufflator. But over the period, CO2 insufflation can also be done, but the only thing is CO2 insufflation, once we start using, it can have a sudden distension which is not under actually our control, and voluntarily only drawback of present colonoscope, the gastroenterologist who has given a nice talk will agree with me that there is no scale that what is the maximal distension of the colon done with this much pressure. We don't have a pressure grading in front of us like in a laparoscope. That is one acceptable factor. And by adding CO2, we are increasing the cost of the normal daycare procedure. So I think this should be taken.
CO2 inflator usually recommended for therapeutic procedures, where it goes for half an hour, 45 minutes, 1 hour. But usually colonoscopy takes 15-20 minutes with minimum air inflation is more than sufficient.
Yes.
2 more points can I add up, ma'am?
Please.
Colonoscopy, 2 most difficult parts in the colonoscopy is 1, crossing the sigmoid colon. Second, reaching the terminal ileum. If you cross the sigmoid column, your 90% of your colonoscopy is over. If you keep on pushing the scope, whole scope can accommodate into the sigmoid colon. So take your time in crossing the sigmoid colon. If you are planning to finish a colonoscopy in half an hour, reach sigmoid colon by 25 minutes. Once you cross sigmoid colon, we will be in a cecum in next 5 minutes. So don't push till you reach the sigmoid colon. Take your time, come out, push, change the position of the patient, make the patient comfortable, cross the sigmoid colon. Once you reach the cecum, next difficult part is reaching the terminal ileum. If you master these two things, you will master the colonoscopy. Reaching the terminal ileum, change the position, give the pressure in the right iliac fossa, take your time and cross the terminal ileum. So these 2 points are the most. And third thing is taking a biopsy. Don't be in a hurry to take a biopsy. Usually 8 samples are needed to diagnose the malignancy, because repeating a colonoscopy again burden for a patient. These 2-3 things, crossing the sigmoid colon, crossing the ileum and taking a biopsy. These 3 things you master, your reports will be perfect.
Again, the splenic flexure is again one of the important whatever difficult steps sir has mentioned. So slow gradual movement, and you within a single start you cannot reach to the right iliac fossa. Gradually advancement, start the colonoscopy and follow 2 step back is always a principle in the life also. I think with this I will take the leave. Thank you so much.